Hello and welcome to the University of Maryland School of Public Health Grand Rounds, co-sponsored this time by the Maryland Institute for Applied Environmental Health. And we are really enthusiastic today to have our speaker, Laurie Garrett. She's a senior fellow for global health at the Council on Foreign Relations. Garrett is the only author to have received all three of the big Ps of journalism, the Peabody, the Polk, and the Pulitzer Awards. Her expertise includes global health systems, chronic and infectious diseases, and bioterrorism. She's the best-selling author of The Coming Plague, Newly Emerging Diseases in a World Out of Balance, Betrayal of Trust, The Collapse of Global Public Health, I Heard the Sirens Scream, How Americans Responded to 9/11 and Anthrax Attacks, and the ebook, Ebola, Story of an Outbreak. She's, over the years, contributed to chapters for numerous books and worked at NPR, been a newspaper reporter, worked in Africa. She started her career during PhD studies at Stanford, at Berkeley, and a University of Stanford University laboratory, interpreting science for lay people and working on a local radio station, which got her hooked on journalism. And she has been, over the years, working in many fields, spent much time in Africa, and brings a global health perspective to the problems that we face today. And it's with a great pleasure that I introduce to our speaker today, Laurie Garrett.
Hi there. I'm a bit of a gimp. I got in one of those going downhill 35-mile-an-hour bicycle accidents and smashed the old kneecap. So forgive me on that, but otherwise we're set to rock and roll. And I have a lot of things to talk to you about today, and I want to start off by giving you some of the good news, because it's easy to get bogged down, especially with my talks, in the depressing, but we do need to keep in mind how far we've come. In the time of Henry VIII, the average life expectancy was about 34, 35 years. It was very rare for children to survive into adulthood, and even by 1800, the vast majority of the world lived less than 40 years, statistically speaking, as a life expectancy. Even the United States, we were only at 44. Today, Prince William can expect to look at a life expectancy of well over 80, and his son can probably go out to 85. And all over Europe, all over the industrialized world, we see the same good news, life expectancy rising. Slight differences one country to the next, but the trend is there, even in very poor countries, India, China, and across Africa. You see the trend is the same. It's just how far along on that trend are they that differs. And when you look at it across the planet, you can see that the lower life expectancies are very much concentrated equatorially, and with Africa and South Asia as the stubborn sort of final areas that are in great need of assistance. So we've gone from a pretty grim picture where 40 was old to now a world filled with centenarians and even post-centenarians, whatever you call somebody 111. And one of the big things that drove all this was eradicating smallpox. Most people don't realize that in the 20th century, smallpox, even though it was eradicated 3/4 of the way into the century, killed more people than all the wars combined of the 20th century. Getting rid of smallpox radically affected the statistics of life expectancy, mainly by decreasing child mortality. And we've seen child mortality plummet so dramatically, even in the most desperately poor countries of the planet, largely because of improvements in nutrition, in water quality, and of course, vaccination. We can say that in 1970, there were pockets where child mortality rates were still very high, but today, none of those bright red, terrible pockets of high child mortality still exist. And we're heading towards a world where children can be expected to live into adulthood. The biggest killer used to be measles. When I lived in Africa when I was in my 20s, children were dying right and left of measles, compounded with malnutrition. It was really quite a lethal cocktail. Mass vaccination has had a dramatic impact, and don't let anybody get away with telling you that vaccines cause autism. And frankly, as you go across the list of things for which we vaccinate children, these are diseases that are disappearing as major health crises, not just for us, but everywhere in the world. We've had a big impact also on reducing malaria, although we still have a very long way to go. And there is great concern about rising drug-resistant strains of the parasite that causes malaria. We've seen really amazing success also with decreasing the numbers of women who die in or around childbirth, maternal mortality. You know, there was a time when most women had more than 4 children, and more than 4 childbirths was an almost statistical guarantee of dying in childbirth. Today, it is very rare, although maternal mortality is increasing in the United States again, driven by the states of the Deep South that have been banning Planned Parenthood and other reproductive health facilities, therefore increasing the drive time for women in labor. We had a statistical period when HIV was actually reversing gains in life expectancy. That has now stopped, and we are having great success by bringing people on treatment. But we still have more than 1 million deaths every year due to AIDS, which means people are really not getting what they need in order to tackle and control the virus. And perhaps much more significantly, we still have 2.1 to 2.5 new infections every year, despite billions of dollars of outreach. And if you just do a bar graph, you can see that by 2030, the new infection pace will have exceeded those that our lives we've saved with medication. So we've gone from 32 being male life expectancy in George Washington's time to the middle of the 20th century hitting about 48 in the United States, to, for men, hitting by 1980, or 2012, excuse me, a life expectancy of 70 years for men, and now still climbing. What's made the difference in the most recent period, of course, is money, and money matters. The United States is a very generous giver, and we should all be very proud of ourselves as taxpayers because the U.S. has been the single biggest donor to global health efforts worldwide, especially to bringing down HIV rates and to tackling the big 3, HIV, malaria, and tuberculosis, through a variety of programs, including PEPFAR, the President's Emergency Plan for AIDS Relief. We've dramatically reduced the mortality, though, as I said, new infection rates are still stubbornly too high. And if we don't deal with that, the gains will eventually be overwhelmed. We've helped push malaria rates down, and another big donor, the number 2 big donor, is the Bill and Melinda Gates Foundation. And with tuberculosis, just since 1990, we've pushed mortality down by 47%, which is amazing, 43 million lives saved. However, we are seeing a rise in drug-resistant forms of tuberculosis. So we're at this strange juncture now, however, where we're trying to figure out, we had these things called Millennium Development Goals set by the UN. Now we're going off in search of Sustainable Development Goals set by the UN, 169 of them. We have a real difficulty because we have too many players in the sort of international architecture of this thing we call global health. And they're all grabbing for money, they're all grabbing for resources, and you throw in climate issues and other, players on the field and the concern about outbreaks, and you start to realize that it's really quite a confusing mess, and there aren't enough resources to satisfy all the needs and all the targets. So that you end up getting to a situation where there's competition set up for funding. The Sustainable Development Goal number 17 is find money. And how much money do they need to reach the SDGs? $4.5 trillion a year every year till 2030. For each year we don't spend $4.5 trillion, we have to backload an even higher amount. Well, trust me, year 1, we've hardly spent anything. We're barely in the billions. So we have a very long way to reach this $75.6 trillion price tag for the Sustainable Development Goals, even if you assume the countries themselves will be able to generate revenues from their own tax base to satisfy some of the targeting, it still is a really ambitious, terribly ambitious set of goals we've set. And we still have the old challenges lurking in the background, the really huge challenges facing fragmented governments. We still have tremendous aching poverty around the world, poverty that undermines the ability to set up lasting health systems and pay people. We still have people like this family I met under the Hooghly Bridge in Calcutta, living in desperate substandard housing all over the world. I'm not just talking about a bad apartment. I'm talking no roof or no water. And as this boy in Haiti showed me, yes, we're beginning to build water pumps in places that have long had unsafe water, but we still don't have anywhere near enough. These are the road conditions that responders had to deal with in the Ebola epidemic in 2014 in Liberia. And we, you know, for all the money that we put out the door to try and make things better, do they last? When we exit, what remains behind? Is it nothing but a rusted out USAID Jeep sitting in a busted up parking lot? All over the world, we have a serious problem with access to medicines and abuse of medicines, especially antibiotics. Available in the marketplace, God knows what it actually is, God knows who made it, and whether or not anybody should be taking it. So these have framed my work for most of my career, starting with my book, The Coming Plague, way back in the 1990s. And since then, we've seen far more outbreaks, far more, not only an increase in the frequency of outbreaks, but also in the severity of some of the worst of them. And this is a trend, as surely as we see a trend of rising life expectancy. In 1995, for example, we had Ebola reappear for only the second known time on Earth in Zaire, now called the Democratic Republic of Congo. And it was in conditions that were almost unbearable. This gentleman constituted the entire BSL-4, Biosafety Level 4 laboratory by himself in a spacesuit that would get 126 degrees inside. So he couldn't work very long without collapsing. We went into that epidemic with really no tools, no diagnostics, no treatment, no vaccines, no idea where the virus came from, no idea what to do for the people who had the virus, or really how to stop the outbreak. Since then, we've seen more and more outbreaks spread to another continent, to a far distant place because of our globalized travel. So you look at just the outbreaks that have occurred in the last 10 years, and the numbers are quite remarkable, and they are really, truly everywhere on the planet except Antarctica and the far Arctic. So let's take the example of the SARS epidemic, which emerged originally in November 2002 in China, but was covered up and wasn't really known to the world until it spread outside of China to Hong Kong, Vietnam, Toronto, and a number of other locations, 31 countries actually, in 2003. This epidemic we now know, was originally a bat virus, and due to widespread illegal hunting of wild animals, particularly in Burma, the Chinese were bringing all sorts of things into their country. They lied, they covered it up, and when they finally said, okay, in April of 2003, we have this epidemic, all heck broke loose. More than 250,000 people fled Beijing. The only way they could control it was the same techniques that would have been used in the 14th century to stop the plague. Quarantine, controlling human movement, testing whether people had a fever, and regardless of the cause of the fever, you were sequestered and quarantined until you didn't have a fever anymore. It was that simple. That was how technically sophisticated it was. And it was finally brought under control in June of 2003. But even when the SARS epidemic ended, we still had no real diagnostic, no effective treatment of any kind, no vaccine, no real clear idea of how to deal with the airborne transmission factor and exactly under what conditions it was airborne versus contact or sneezing or something else. We still had very few laboratories around the world that could do the kind of work necessary to understand and deal with the virus. We still didn't know where it came from. It wasn't until more than 10 years later that the bat species it originated in was determined. And we still had, it showed that we didn't have a vaccine, and then along comes in 2012 its close genetic cousin, the MERS virus, Middle East Respiratory Syndrome virus. And if we'd had all these problems solved for SARS, we would have been far ahead with MERS. Unfortunately, we've now had more than 2,000 deaths from MERS. It has spread, but is primarily in Saudi Arabia, which affects the Hajj and all the sacred Islamic treks and pilgrimages to Saudi Arabia, resulting in isolated cases of spread and a pretty significant outbreak 2 years ago in South Korea coming from Saudi Arabia. So, outbreak after outbreak, we see the same shopping list of problems, and they never seem to get answered. We approach outbreaks, even though we're a high-tech world, with no tools in the toolkit. Along comes Ebola in Liberia, Sierra Leone, and Guinea. In 2013, it started right after Christmas in Guinea and spread quickly across the borders to the neighbor countries. By August, it was enormous. And it was the first truly urbanized Ebola epidemic we'd ever seen in the 3 largest cities of West Africa. And still, the world was doing almost nothing. It wasn't until August that WHO declared a state of emergency. And there was really not a sense that it was a problem for the world. It was a problem for those 3, countries we don't care about, but not for the world, until we had an isolated case in Dallas, Texas, 2 infected nurses, and then it's the ISIS of biological agents. All hell breaks loose in the United States because of 3 human beings. We go completely crazy, and our epidemic is an epidemic of fear, not of Ebola. But because of this epidemic of fear, we are reluctant to come to the aid. We will not provide the kind of resources that are needed. And the whole world commits to resources that never actually materialize to assist or come so late in the game that they're of little utility. In fact, if we take each of the 3 epidemics apart, you can see they were quite different. None of them had a tax base of their own to draw upon. None of them had financial resources indigenous to the countries. In the case of Liberia, what you saw was that the first real outbreaks were all in healthcare facilities. And in every case, a huge toll was taken of healthcare workers who didn't have the proper protection, didn't know how to protect themselves, and eventually would abandon the hospitals, deserting their supplies and their patients because the risk was so high. And so many of the public hospitals were shut down. They didn't have enough healthcare workers to begin with in these countries before Ebola. And after Ebola claimed so many lives among healthcare workers, they go into 2016 with a real paucity of physicians, nurses, lab technicians, ambulance drivers, the entire range of what we call healthcare workers. And this situation will not get fixed anytime soon. You can only train community health workers to do so much. We could have stopped the epidemic. We had the toolkit. We knew enough. We'd seen enough Ebola in the world by then. There had been 19 outbreaks of Ebola around the world, and yet the resources were not committed and not mobilized. If you look at Liberia, you can see that what brought it under control, and it was brought under control before the international mobilization in September 2014, were things that weren't rocket science, nothing high-tech. It was pretty basic stuff. It was figure out who looks sick, separate them from the community and from their families so that they stop transmitting, put them in isolation, stop the funerals that were becoming sources of spread, and bingo. Most of the resources got there too late. And so the community mobilizations of Liberians by and for Liberians were the key, whether they were the urban mobilizations to convince people, yes, there's a real disease and you need to pay attention, or in the rural areas, or in setting up evacuation and quarantine centers, and properly separating the maybe infected, we're not sure, the laboratory confirmed infected, and the convalescing from the rest of the population, and from healthcare workers wearing proper barrier protection, knowing how to clean and reuse that which could be, and gaining enough outside resources from the rest of the world to have disposable gear where cleaning could not sufficiently protect the individual from exposure to Ebola. So that this is a MSF facility, regardless of what facility. The point is, Liberia, with some small outside help, stopped its epidemic. But the losses at the village level were serious. This village I went to, for example, there were whole households wiped out. And this imam had just lost his wife and 2 children, and the day before I met him, and the whole family was in a state of shock, recovering from such tremendous loss to the household. Everywhere at the village level, chiefs set up isolation and placed people in quarantine, as you see this group here, and they would not be allowed to leave the facility until it was proven that they did not carry Ebola. In the cities, there were hand-washing stations at every store, every building of any kind, any public facility, with chlorine, and that was the national odor of Liberia. The United States taxpayers set up a biohazard level 4 facility deep in the middle of nowhere, Liberia, with Liberian scientists and able to work on live virus. In this facility, they made a crucial finding that dead bodies, 5 days dead, had more active virus on the surface of the body than in the bloodstream of ailing patients. That was a huge clue that the funerals were the key of transmission. The preparation of the burials, the touching of the bodies. This had to stop, and it did. And for the most part, Liberia had its epidemic under control by December of 2014 with isolated outbreaks, all as a result of the virus hiding in semen and passed sexually to the sex partners of Ebola male survivors. Nobody knew the virus could live in semen for more than 500 days. This changes your sense of when is an epidemic, quote, over. In Sierra Leone, it was a totally opposite situation. They did not get their epidemic under control until well into 2015. It actually was skyrocketing when Liberia's was coming under control. And again, it wasn't rocket science that brought it under control. It was taking the proper steps after some missteps. The Sierra Leone response was led by military forces and military personnel, and so it had a very different flavor to it from Liberia. It involved quarantining entire regions, in some cases the whole country. As you would enter a hospital, these fellows would make a decision. Do you look like you might be infected? If they suspected you were stuck in this outdoor facility in the blazing sun, and people died without ever getting in the hospital, right on the street. If they were lucky enough, as you see this fellow peeping out from the quarantine door, to get in the facility, they often were handled by healthcare workers that had lost many of their loved ones to the disease, their colleagues. Eventually, the Cubans arrived, and they provided hands-on healthcare in hundreds of them and made a huge difference. Only one Cuban healthcare worker became infected, and he survived. The Sierra Leone facilities were similar to those in Liberia, but with fewer margins of protection, and they kept their convalescing, cured patients quarantined for longer. They still came out of it with no point-of-care diagnostic, no effective treatment, no clear idea of how to deal with airborne transmission effectively, still limited lab capacities, origins unclear, though we're very well down the road on a vaccine and may be able to mass vaccinate all over Africa in the future, it's still not exactly there. Monetary needs never were fully met, and not long after this, the United States Congress says, take the leftover Ebola money and use it on another disease, which we will now come to. And that would, of course, be Zika. But the question is, can we learn from the mistakes? Huge mistakes made. WHO took them 8 months to get around to declaring a state of emergency and calling for global mobilization. Where were they? Where was the United States? Why did it take our military months to get in place to help and assist? Similarly, the British military. Can we do better when we fight the next epidemic? And will we have a better organized international health architecture of response and a better WHO? These are all still open questions. The reform process is going on, but you know, it's a long way from reaching the kind of finish line that would make us feel safe. So that takes us to Zika. It was first discovered in 1947 in the Zika forest of Uganda, but we didn't really have an outbreak until 2007 in a remote Pacific island called Yap, then the Polynesia, and now South America. The Zika forest, it was found in test monkeys, but no human cases were identified in the early days in the 1940s and 50s. And only a handful had been identified around the world, including Indonesia, until 2007 with the Yap outbreak. And this outbreak started in April, ended in July, and by then 73% of the population had been infected. It's an amazing, that's like a influenza outbreak. That's a huge pace of exposure, especially for a mosquito-carried virus. The age distribution and the symptoms are interesting because most of the cases were older people. There wasn't a huge distribution in the young reproductive age, your age group. And as a result, most of the symptoms were pretty mild. Rash, fever, achiness, don't feel great. That pretty much is the limit. They didn't see anything that looked life-threatening, and they certainly didn't see any birth defects. In 2013, it hit French Polynesia, you know, Tahiti. And they had a very different age distribution, and they saw a lot of cases of Guillain-Barré syndrome, which is a syndrome caused by the virus attacking neurons and resulting in partial or permanent paralysis of the victim. And that year, there was a FIFA preliminary trial in Brazil, and the Polynesian team went to Brazil. That took the virus in their blood. Local mosquitoes fed on them. Brazil happened to have very large populations of Aedes aegypti brought via slavery in the 16th century and 17th century, and of Aedes albopictus brought in the 1980s in transport of used tires, the tires forming a great spot for the larvae to grow during the ocean transport. And both of these mosquitoes had adapted to the urban settings across Brazil. The other part of the perfect storm is that carried by those mosquitoes, they'd already had outbreaks of yellow fever in Brazil, dengue, with more than 250,000 cases, and chikungunya, another sort of rarely heard of virus that turns out to make people pretty darn sick. And these had spread widely across Brazil, carried by the Aedes aegypti mosquito. Exactly how significant it is that these coincided, especially this huge dengue outbreak, with the various quarterfinals, preliminaries, and then World Cup isn't clear. However, there's a belief that there was a priming effect on the immune systems of Brazilians that were exposed to these diseases. Now, the interesting thing is this is the belt of chikungunya. Let me go back one. Here's the belt of the distribution of chikungunya in the world. And pay attention to that geography. Now, here's the history of the movement of Zika. It's obviously the same geography. And what you're looking at is a virus that starts in Africa, makes its way across the Asian belt, the Pacific belt, to Easter Island and to Brazil. That happens also to be the Aedes mosquito belt. So perhaps not entirely a surprise. The other perfect storm event for this outbreak was El Niño, which resulted in a dramatic change in all the weather patterns of Brazil, changes that favored mosquito breeding, and in particular favored the behavior of the Aedes aegypti mosquito. And then finally, Brazil was in a crisis of governance, and during this outbreak impeached its president, and has the majority of its parliament is facing indictment or is indicted on corruption charges. So along comes Zika, and at first the major trademarks of this virus that were known were a torso rash and fever, and maybe a little myalgia, achy muscles. That seemed to be it. The key elements of how you controlled mosquitoes were known: larvicides, insecticides, get rid of the water that they might put their eggs in, get rid of the refuse and tires and all the places where water could collect and where mosquitoes could lay their eggs and the larvae could grow. But of course, everywhere in the world, when you go in to use your chemicals to get rid of the larva, you get resistance, not from chemical resistance, but political resistance. The question we have had all along is whether or not the Culex family of mosquitoes could carry Zika. Why are we worried about Culex? Because these are our indigenous North American mosquitoes. They are everywhere. And if you get bit, odds are it was a Culex that bit you. They go all the way up to the Arctic. Experimentally, they can be infected with Zika. Experimentally, they can transmit it. Some infected Culex have even been found in Brazil, but it's not thought that so far most of the Culex species have adapted to carrying the Zika virus. So if you look month by month, you can see there was a real explosion this time last year in Brazil, and that spawned the global concern. I argued in January that once it was in our mosquitoes, it was not going to go away, that we were facing the possibility, if we allowed it in, that it would be a permanent feature of our landscape. And the actual public health emergency was declared by WHO on February 1st of this year, and the reason was microcephaly. I think it's important to note, it wasn't because a lot of people were sick. It was quite specifically because Brazil saw a 20-fold jump in the number of babies born with misshapen skulls, this syndrome that we call microcephaly. All across Brazil, mothers started having these babies that were severely deformed. In many cases had this muscle distension that was permanent, had gag reflex and could not swallow, could not eat. Brazil went from 150 roughly identified Zika cases in 2014 to more than 4,000 in 2015, and the numbers just keep rising this year. So that babies were born with shrunken and misshapen skulls as the major hallmark of it. And what you can see in the white on these brain scans is huge amounts of calcium deposits. Absolutely enormous amounts of calcium. And what this is being expelled by, let me go back 1 second, expelled by cells that are dying as a result of viral contamination of the cell, and in the process are sending out chemicals that are altering the actual formation of the skull and leading to this massive deposition of calcium. Wherever you have a giant pile of calcium, you don't have room for brain cells. And so you begin to have a competition in the developing brain between calcium, neurons, and the shape of the skull itself. And it begins to take a very serious toll across all of Latin America starting in January. And I'm sorry the print is very small here, but here are the key findings published recently of what has been seen. The first is, it doesn't matter what trimester the mother is infected. All 3 trimesters are dangerous for the fetus, perhaps greater danger early, especially for the skull shape. So the misshaping of the skull can include that classic microcephaly, but also just dents and ridges and sort of calcifications of the skull. This also affects their behavior. These kids are in pain. They are very likely to have club feet, difficult skeletal problems, and epilepsy, seizures, a whole variety of seizure disorders, and they are screaming and crying in pain almost all the time. So this misshaping is because very clearly they could see, even before they figured out exactly what was going on, not enough brain cells are being made to push the skull out in the developing child's head. So if you look at this example from Brazil, or Colombia actually, you have two twins born in separate but both infected placentas. The nature of the misshaping of their skulls is different, but they both were born with grossly misshapen skulls. And the full syndrome of what we call microcephaly affected both of them. This is all beginning to remind people of 1964 and the German measles epidemic. In that year here in the United States, we had an enormous epidemic. 20,000 babies were killed by rubella, and at least another 20,000 suffered a congenital disorder that included being the leading cause of deafness for that whole generation of children, blindness, and on many other issues. Well, we're starting to see the same range in Zika babies, with or without microcephaly. They're very likely, if exposed to Zika in utero, to be deaf or suffer severe hearing impairments or difficulty in processing sound in their brain properly. Their eyes are improperly developed, and so they have huge visual field problems. They may sort of see, but it's seeing like a blur. It's seeing things that you cannot interpret. As I said, they're having bone skeletal issues, hip, knee, arm, joints simply not forming properly. And this seems, again, to have something to do with this calcium issue. So they may appear normal, except when you start to study their arms and legs and you realize that they are completely distorted in skeletal structure. They often have hyperflexing or hypoflexing, and they cannot unflex their hands, fingers, arms, legs, or have club feet. We now know that the virus actually infects immune system cells of the mothers in the placenta and carries inside to the fetus using these immune system cells as a Trojan horse effect, getting into the amniotic fluid, and in green are the immunofluorescing infected cells. These all turn out to be, in the fetus, neuroprogenitor cells, what will, if allowed to live and grow, be differentiated brain cells. But as you see again in the green and another kind of cross-section, the cells will simply die as a result of infection. We've now got several animal models, mouse and primate, to show that this mother-to-child transmission is real and how it occurs, and that it often involves women who have symptoms like the classic rash, but just as often, the mother has no symptoms and had no idea she had Zika, which makes everything about the diagnosis of this very difficult. You may say in some cases the sort of, good news is some of these babies miscarry. They're not viable. And more often, they are born, and these mothers are experiencing tremendous burdens and psychological stress trying to deal with these babies. We have, a generation of babies born in Brazil now where the mothers are completely overwhelmed. And as one set of mothers sees another set, more and more pregnant women are opting for abortions. Even in countries like El Salvador, where it's a mandatory 30-year sentence to have an abortion, we're seeing a skyrocketing abortion rate. I asked in July, was Zika transforming into a sexually transmissible disease? A little hyperbole by the publishers to call it the next HIV, but the point is taken. It seems to be behaving as an STD, so you have more and more men transmitting to women, and in one case, a woman transmitting to a man, and men to men. So, this is like what we've seen with meningitis, we've seen with Giardia, with Ebola, with hepatitis A. More and more microbes that we think of as transmissible through only this list of means are turning out to also be, in special circumstances, sexually transmissible. And that gets us back to the point I was making about the distribution of the age and who's getting Zika. So in Rio de Janeiro, the vast majority of people who got Zika were between 15 and 35 years of age, and were female. Now, if this is just being transmitted only by mosquitoes, there's no reason whatsoever that twice as many women should be infected as men, and that they should be distributed in a particular age group that is the most sexually active age group. Again, let's go back to the Yap Island distribution. Remember, I pointed out to you that they tended to be older. Or let's compare it to dengue distribution, which has no gender difference to speak of and distributes according to the general age of the population. New evidence shows that in adult mice, Zika kills neurons as well. So it's not just the fetal cells. And this may be meaning that some of the Guillain-Barré syndrome cases are going to be permanent. Very new study just published last week shows that these neuroprogenitor cells are actually developing in a normal, healthy human all the way out to year 2 of life. And therefore, the right cell population is there for exposure to newborns. But we don't have a way to tell the difference between a baby born with some minor Zika effect or a baby bit by a mosquito at age 6 weeks, and to know which is the key problem. We also now know it can have damaging effect on the entire spinal cord, and in rare cases, the Guillain-Barré syndrome can be lethal if the paralysis is in the diaphragm, the lung muscles, and the heart muscles. And there have indeed been adults that have died of Zika. Very rare, fortunately. So let's go to Miami. On July 29th, the government announced of the state of Florida, we have, in fact, found mosquitoes, Aedes aegypti, and they are in the Wynwood neighborhood, and they carry Zika, and we have confirmed that people are getting it from our local mosquitoes, not just travelers. This is the neighborhood they're talking about. It's sort of like hipster ground zero for Miami. It's like cool outdoor bars and loads of graffiti and murals and all kinds of, late night hipster scene. And it doesn't really look like, a swampy, mosquito heaven, does it? You also notice not very many people. That's because everybody has fled. Where it is today is there are 3 pockets of Miami where they have captured infected mosquitoes. This Wynwood area I was showing you, South Beach, and they just announced this week Little Haiti, which, I was surprised they hadn't found earlier because almost all the women I'd talked to who had Zika and were pregnant were Haitian. Almost all the cases can trace to those zones. They're working with the Centers for Disease Control in a whole emergency operations mode. And of course, it's spread all over the world and now is really exploding in Singapore and Thailand, with the threat of becoming a very serious endemic problem in the area that is already endemic for dengue. So the Zika saga takes us from 1947 in Central Africa, slowly making its way around the world, and now all the way across that entire belt I was showing you, the Aedes belt, to Southeast Asia. And so far, 73 countries have had Zika since 2007, almost all of them since September 2015. In 17, they have found infected mosquitoes and can prove it's local transmission, not travelers going somewhere and getting bit. 12 countries have had human-to-human sexual transmission or transmission via tears and saliva. In February, President Obama asked Congress for $1.9 billion in emergency money to combat Zika, to fight the mosquitoes, to do massive research, to come up with a vaccine. Congress said, just take the, quote, leftover, end quote, Ebola money. This was all committed money for the people who'd been through Ebola. And the White House said no. Then it exploded in Puerto Rico, and now 1/4 of the Puerto Rican population has had infection with Zika. And it points up, if every time we have an outbreak, we have to go to Congress and beg, then every outbreak is going to find the necessary resources locked in partisan bickering. It's an unacceptable thing. We actually ran out of all Zika money just by robbing from one account to another, even from cancer research, just to get a vaccine trial started and to get a diagnostics studied and up and running and producing them. It means that we have a very perverse situation that must be corrected. We can't enter another epidemic like this, where Congress tells the civil service, oh, just find money somewhere. Finally, on September 29th, as part of the overall budget process, Congress passed what's called a continuing resolution. If you don't know what this is, you should look it up, Governance 101. And 251 days had elapsed since the president had requested $1.9 billion on an emergency basis, and they gave him $1.1 billion 251 days later. Not the right way to run a railroad. And some of the research questions that we should have answered by now but didn't have the resources to deal with are trying to figure out some very basic issues. How do you test a pregnant woman and give her reliably some sense of the status of her fetus? If we give people a vaccine, could it actually worsen the situation? Because that's what happens with some dengue. You get exposed to one strain, it doesn't immunize you. It sensitizes you for a worse case of dengue with the next strain of dengue or with chikungunya. And we don't know if perhaps Brazil's epidemic is so bad because they had dengue and chikungunya. What's going to happen to these babies in the long run? Not just the really obvious microcephaly babies, we know they're doomed. But what about the babies whose infections so far just involve some hearing loss? When they start, will they walk on time? Will they be able to go through school? Will they be able to read? What we can see, the very first identified cases are now a year old or approaching their first year. And we see they have seizures, they can't swallow food often, they gag a lot, they have hearing failures, some of them are completely blind, and they really can't get through a day without constant tending, constant attention. Literally, some of them can't breathe if their neck isn't held in the right position for them at all times. And they are often in so much pain that they can't stop crying. And so we're not sure they even sleep, some of them, because they are literally crying all the time. Can we predictably tell a mother, okay, your baby was exposed, but good news, no damage, or yes, damage? Right now, none of the standard pregnancy tests are helpful in any way. We don't know how much is human-to-human transmission, how much is sexual transmission, like the case you had here in Baltimore. A person with no symptoms, no history of knowing he'd even been infected, and he passed it sexually to his partner, harboring it in his semen, like the Ebola virus harbored in semen, and there, I just destroyed that. We don't have good diagnostics, and we have a really hard time discriminating between a history of Zika, dengue, and chikungunya. They all cross-react in your blood. And so we can't really go out and do the kind of epidemiology that would say, what's the baseline? Are we all worried, but there were actually 12 million people infected? Or are we all worried because it was actually only 100,000 infections and all these ailments we see? What mosquito repellents work? What pesticides work? CDC's Florida work says you need to come in with a double whammy of 2 different pesticides plus a larvicide and slam the neighborhood with all of it at once. Good luck with that politically. Will Zika adapt to be carried by other mosquito species? And can it infect indigenous monkeys of Latin America, as is the case in Africa, and therefore seem to disappear, but be in the monkey populations in the Amazon, and mosquitoes can bite the monkeys and bring it back out into human beings, which would mean we'd have a multi-year, perhaps decades-long, permanent feature of our public health landscape that would appear and disappear seasonally. That's what's happened with dengue. That's what's happened with chikungunya. Is this what will happen with Zika? And now, since Hurricane Matthew, we're all very anxiously watching Haiti. Will they have a Zika outbreak? They already have Zika, but will they see it really explode? You know, they had an earthquake in 2010. Before then, they had no cases identified of cholera in Haiti. But since 2010, since the earthquake, Haiti has been overwhelmed by cholera, the prior great natural disaster this country faced. It's had more than 10,000 deaths. MSF says that guesstimate is off by as much as tenfold because of underreporting. At least 780,000 cases identified, and it is coming back up again. Great fear that the hurricane, with more than 1 million people now homeless, is going to cause cholera to surge once again in Haiti. So Haiti could really be looking at the double whammy of cholera and Zika going forward over the next year. And I just want to close with a couple quick cautionary notes. I did mention successes with HIV, but if you do the math and we keep allowing the new caseload and death load to go the way they are, what looks like a small number is going to turn into a huge number, some 18 million deaths, some 30 million more HIV cases by 2030. That's obviously unacceptable, and we need a new set of tools. It's not enough just to treat our way out of that epidemic. And child mortality, I honestly believe this whole map could be made pale yellow, and all the children of the world would have a reasonably same opportunity to live into adulthood. I think the world could also see life expectancy extended even in sub-Saharan Africa to the sorts of differentials that we saw between Henry VIII and Prince William. And these are the hopes for the future as we go into this period of sustainable development goals, of trying to deal with climate change, and of all the great crises of the planet which cross borders and require massive amounts of money to address. Right now at WHO, the World Health Organization, a lot of the funding is in their budget stated as a budget line, but there's not actually money in a bank account for that budget line. I call it fairy dust financing. And it is sort of the way that WHO tries to put on a good face. But the truth is, the World Health Organization is funded by far less today than when adjusted for inflation it was funded with in 1990. We have elections underway now with 6 candidates running to be the next leader of the World Health Organization. The election will take place next spring. And all of them are reasonable. None of them is a showstopper. And we can all keep our fingers crossed that whoever takes over is going to be able to make the right structural reforms and raise the right kind of money to make all of us feel safer in the world going forward. Thank you. I think I have time to take a few questions, and there is a microphone if anybody has questions. This always happens. I sort of dull everybody into, speechlessness. Here, I see. Can you bring the mic over? I hear it. I hear you handling it.
You do?
Yeah.
All right. Thank you, Laurie. I'm Sandra Quinn from the School of Public Health. So,
Is everybody in the back hearing that? Is it, okay.
I'll be really loud. How's that? You've made a compelling argument that we can try to address each of these as they come along, but we're not making a concerted and coordinated effort over time to develop an infrastructure that can help us both in these countries that are just devastated by poverty, and an infrastructure scientifically and governmentally to be able to respond to these. So the question is, this is the $64,000 question, or $64 trillion question maybe. how do we make, in the environment in which we live today politically, how do we persuade, at least here in the U.S., that we have a stake in the health of the rest of the world?
So, what you're asking is, it goes to the bottom line question of global solidarity and recognition that what threatens one threatens all. The first problem we have is that what has globalization meant in the end? There was a lot of excitement about this word, globalization, 15 years ago. But now we're facing an election today that in many cases is a election about globalization in the United States. And a lot of anger and a lot of rage because so many people feel that the 1% took everything and what happened to them and stuck and left out. On a global scale, when the United States government goes to other countries and says, we want you to improve your disease surveillance and response capacity, and we're going to help you, and as the Obama administration has with its global health security initiative, we'll bring in some CDC folks to train you, we'll provide resources and so on. When they say that, a lot of the governments come back to them and say, you want to protect Americans. So you want us to build an infrastructure, but not to protect our people, not because you care about our people, but because you don't want these things to end up in Dallas. And we're not really sure we like this concept of security. Because when we hear Americans say the word security, we assume you're talking about ISIS and Al-Qaeda, and you're trying to turn the whole world into a military state. And that makes us very anxious, and we're not really keen to cooperate when we hear that. And on top of everything else, you want us to share the risk of outbreaks, but not the benefits. So when H1N1 flu happened, the swine flu in 2009, we didn't get vaccines. It only went to you Americans in rich countries. When we need Tamiflu during a flu pandemic, we don't get the drug. Hoffmann-La Roche sells it all to Europe and the United States. And with cholera, where's the cholera vaccine? We hear there is such a thing, but we're not seeing it here in this impoverished corner of Haiti. And I bet if you come up with a vaccine for Zika, well, probably the folks in Belize won't be getting it. In Haiti, it won't be getting it. In the poorest parts of Brazil, won't be getting it until after all of Florida has gotten it, all of Texas, every human being that wants it in Georgia. So you're asking an awful lot, say those countries. The Obama administration has tried to come back with a reasonable honesty and recognition of the disparities, but still arguing it's in everybody's interests for us to not face a world of unpredicted black swan events. And if we can head off the next Ebola and declare an emergency without waiting 9 months and having thousands of deaths, but be there on the spot, very first cases at the village level, isn't that better for everybody? I think the problem we face now is until we know who's the next president of the United States, we don't know where any of these initiatives that were set up by executive decision in the Obama administration will go. Of course, you won't find anything in policy statements from the Trump candidacy saying, this is what I will do with this part of public health. I actually would really welcome for anybody to do a search of all of the Trump websites and what have you, and let me know if you find anything about global health at all. And on the Clinton side, she certainly has a long track record that we can turn to, and the Clinton Foundation, which is now being destroyed, has a long track record we can look at. And Chelsea Clinton has a PhD in public health and is very much involved in these sorts of issues, particularly the governance side of global health. So there's some reason to be optimistic However, we don't really know where she comes down, she being future President Hillary Clinton, on the question of whether or not to maintain the Obama administration's global health security initiative and what it should look like and so on. And then finally, you know, Congress, it's remarkable that most of Congress paid no real price politically for stalling for so long, 251 days, on Zika money, even when we had an actual Florida-based transmission series going on. And some of the members of Congress, the ones that, you know, remember how to brush their teeth in the morning and other basic human functions, realize that this is no way to run a railroad, that we've got to have some kind of an emergency reserve that's depoliticized. So there are various permutations of a bill floating around both the House and Senate side that would create a fund, the size of which varies according to which bill you're looking at, that would be an emergency reserve. It would be nested at the CDC, and it would have very specific triggers for its use so that it couldn't be, you know, pulled away for some senator's favorite seatbelt program or whatever. It would have actual triggers built in. And this is similar to something going on at the global level, that the World Bank has created a world finance center for future epidemics. And it's meant to have a series of triggers that release those funds in an outbreak. That one is nowhere near its multi-billion-dollar level. It has a novel, innovative financing scheme, which I don't have time to get into. It's very complicated, and it's not at all clear it will work, because it's actually calling on the, you know, investment community, the private sector, to invest in sort of epidemic futures in a way. And the trigger issue is a big deal, because if you think that WHO dragged its feet in this last Ebola outbreak, do you trust WHO to announce and trigger and direct money appropriately in a timely fashion? So there's a long answer to your question. I think we had at least one more hand. Here we go.
So, Mike, hi there. Thank you for your talk. My name is Dina Borzakowski. I'm also from the School of Public Health. My question is actually somewhat related, but also pertains to a comment you started with, which is that there are too many players. So moving from the US to more of a global perspective, what would be some of your advice for either a global organization that works in different countries? Would you stick with the World Health Organization model, or would you try to bring in another type of model?
Thanks for an easy question. You know, some of us have put years into this, trying to figure out. And one time I was at a meeting at one of the Davos conferences, the World Economic Forum, and I won't say their names because it would embarrass them, but a very, very, very famous economist and a very, very, very famous public health person and I were all seated at a table, and the public health person was going on and on and on about how much he hated WHO, what a train wreck, oh my God, example after example of, you know, incompetence and malfeasance and foot dragging and blah, blah, blah. And the economist said, oh, you think that's bad? Let me tell you about the IMF and the World Bank. And he starts his list of blah, 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 blah. And I said, well, what do you guys think should be done? And simultaneously, they said, tear down WHO, tear down World Bank, get rid of them. And I said, then what? Well, then that's the problem. It's sort of like, what's that famous Churchill quote? Something like, democracy's the worst system except for all the others. It's hard to imagine that in the contemporary world, well, but let me put it this way. I think the likelihood that the United States Congress would pass the Bill of Rights if we decided to do a new constitution, is pretty close to zero. And I similarly think if we in the 21st century tried to do what was done in 1948, creating the charter of WHO, whatever the result would be worse. So we're kind of stuck with it. Now, at this point, the problem with the WHO is twofold. First of all, it's actually governed by its own assembly legislature. And the legislature meets once a year, and the meeting lasts 2 grueling weeks. And during that time, typically what happens is the legislative body, which is basically the ministers of health of 194 countries, says we want WHO to also be doing X, Y, and Z. So the list gets longer. Every meeting, every year, start out doing all these things and add and add and add, but no added money. And the legislature has not voted a mandate to increase its dues in more than 38 years. So basically, when you adjust for inflation, every country is paying less. And the core budget of WHO keeps going down. Now it's about 80% voluntary contribution to its budget. And what that's done is, who gives voluntary money? Well, the United States, number 1. Distant number 2, the UK, or excuse me, it just switched. UK is number 3. Number 2 is Bill and Melinda Gates. So you have an entity that isn't even a country as the number 2 donor. And nobody knows what the heck to do with that because they're not allowed to vote or, be part of the governance. And then you go way down in scale to hit the next bigger donors, France, Germany, and they're way down here. And the vast majority of countries give such a paltry amount of money as to be negligible in the actual operating budget. And yet, they operate based on a one country, one vote basis. So Vanuatu has an equal vote to China, and Luxembourg has an equal vote to India. And this is a pretty strange way to govern. The end result is that we have a limited range of options for what to do to improve WHO unless we can make the countries of the world all agree that they've got to put more money into the pot, they've got to raise their dues or the expectation, which is all based, by the way, quite judiciously on GDP. So a very poor country pays a very small amount, and a very wealthy country pays a very great amount. However, when you look at how much India pays, it's negligible. It's negligible compared to a far smaller population like Portugal or Denmark. So the whole system is operating in a way that doesn't make any sense. It makes sense historically. You understand why it is that way, but and then finally, starting back in the early 90s, late 80s, there was a real dispersal of power to the regional offices. So, for example, for the Americas, the regional office is the Pan American Health Organization. And it is very difficult for Geneva headquarters to get policy shifts and mandates out at the regional level. And some of the times the regions just completely ignore Geneva. Whatever Geneva says, they're just like, couldn't be bothered. So you have a governance problem just within this thing called WHO itself. And then finally, we have a real tension throughout public health about setting our priorities between NCDs, non-communicable diseases, like cancer and heart disease, versus outbreaks, infectious diseases, the big child killers. And in a way, you could think of it as a tension between things that will kill people in middle and old age versus things that kill people when they're under 12. And when WHO was formed, the world was a world in which most mortality that wasn't what you call old age was children under 12. And today we're in a world where, as I showed you, more and more people are living longer. And it's not actually that individuals live longer, but that societal life expectancy is improving because that burden of child death is disappearing. And so this is creating huge tension inside WHO about what to do with their paltry budget. You know, emphasize fighting cancer, emphasize fighting heart disease, emphasize fighting the next outbreak. And I don't see this being resolved anytime real soon. The one good news thing I will say, and of course I live in New York City, so I'm very biased on this, but Mike Bloomberg is now the newly appointed UN ambassador on non-communicable diseases. And he has already made it very clear that he sees this as, number one, attacking the tobacco industry and making countries go tobacco-free. It's not enough to make the room tobacco-free, make the country tobacco-free. And they issued, under his urging, last week their first big anti-sugary drinks announcement from WHO. And they are planning on tackling salt. So the sugar, salt, and tobacco industries, you know, fair warning. If we're going to go the NCD route, what we know works with infectious diseases is prevention, right? So it's vaccines and hand washing and good hygiene and safe water, right? So with the non-infectious, what works is get rid of the big killer causes of poor health. And outside of infectious diseases, it's sugar, salt, and tobacco. Way in the back.
Thank you. Hi, my name is Apongu. I'm in the Scholars Program for Global Public Health. I just wanted to ask about how they're doing to address the cause of Zika, which is the mosquitoes. It's one thing to help the families who are facing this epidemic, but it's another thing to look at the cause of it. So do you think they're doing well enough in addressing the mosquitoes which cause the disease? And do you also think it's necessary to do that? And so as to a lot more care towards the families who are facing this epidemic? I just want to see your point of view.
Right, good question.
Thank you.
You know, Aedes aegypti, in its natural habitat hundreds of years ago in Africa, was a jungle mosquito. It was the classic, what we call sylvatic cycle. It went where other primates came to the villages, bit the people in the villages, went back into the forest. What has happened over the last 25, 30 years has been a really radical urbanization of that mosquito. And it has come to love humans better than pet dogs. It's in your house, it's under your house, it's all around your house. And they put their eggs in anything, any drop of water. Literally, a thimble of water is more than enough for a female to lay her entire larva sac and for those larvae to grow. So in urban settings, where's a thimbleful of water? Just about everywhere, especially right after it rains or right after somebody does the, idiocy of using water to wash the sidewalk, or wash the car or whatever. So it's everywhere. And wherever you have rubbish, you especially get collection untended of water plus mosquito larvae. But Aedes aegypti is also very good at exploiting any kind of water storage that's used in drought areas, where people put out a water can or a cachement system, anything like that. All of this is very, very hard then to get rid of the mosquito, because it's almost like asking humans to find water in a whole new way and to live in a completely different way in their own urban environment. And the poorer people are, the fewer options they have for changing the way they do things. So not surprisingly, there's more mosquitoes in poor areas. There are two big efforts underway. One, the Gates Foundation is funding experiments using a bacteria called Wolbachia that infects male mosquitoes and sterilizes them. And so they're trying to figure out ways to release the mosquito or the bacteria either by infecting male mosquitoes and releasing them to go out and be carriers of basically what amounts to a mosquito epidemic, or some way to seed the bacteria itself in habitat areas where the mosquitoes are likely to be. And the other is genetic engineering and CRISPR technology. It turns out to be really easy to alter the genes of the mosquitoes. And forms, now I'm going to knock the whole podium over. Forms have been created, genetically modified, that in fact are either sterile or there's something wrong with the male. There turn out to be a lot of ways to attack male mosquitoes. There's even what's called gene drive, and some of you that follow CRISPR technology will know. Gene drive guarantees that whatever you change is going to be passed through the lineage. So all mosquitoes of that breed in that area forever will carry that trait. Very controversial whether humans should do that and what might be the untoward effects that you can't anticipate. But bottom line is a lot of these different things are being tried right now. And in Brazil in particular, they're quite aggressively trying the release of genetically modified mosquitoes. And they have in fact seen rates of disease go down, not just for Zika, but for dengue and chikungunya as well, in some key areas where they've done experimental releases. The only large experimental genetic engineering releases I know of in the US, one was supposed to take place in Puerto Rico and one in Key West, Florida. Well, the Puerto Rican one has come up against claims of this is a racist experiment, you're trying to protect white Americans by experimenting on us Hispanics here in Puerto Rico. And the Key West one has come up with, you're trying to experiment, we're a bunch of hippies, we really like it being hippies, and we hate chemical companies, and this all somehow has something to do with Monsanto, so go away. And you know, the NIMBY problem, is the not in my backyard, is a big, big issue in the United States. It's very hard to do mosquito abatement programs effectively when you come up against community resistance, unless you have garnered very strong political support from your mayors, governors, city councils, and so on. I think I can take one more question. Over here.
Hi, I'm Amelia. Can you hear me? Okay. I'm staff at the School of Public Health.
I don't think it is working.
Do I talk louder? Okay. This is kind of a simple question, I think. You've seen a lot. Is there anything that keeps you up at night when you think about the future, like any one infection or scenario?
So this is the what scares me question.
Yeah.
I usually get this in one of two ways. Either someone asks, gosh, you go to all these epidemics, aren't you scared? Or somebody asks, what keeps you up at night? What worries me, I don't know if any of you will have seen last fall, Lancet did a special issue on planetary health. Anybody see that? It was really a landmark, one of the most intellectually rigorous and innovative things I've seen come out in public health in a very long time. And I've been very concerned about the nexus of climate change and the environment vis-a-vis human microbiome, environmental microbiomes, and the possibility of really damaging how we live on this planet and what's inside of us and outside of us. And that kind of goes beyond any specific pathogen to another whole tier, another whole layer. A couple of examples of things that would fall in that category. One, any of you know what a saiga is? So a saiga is a Central Asian antelope, and they've been hunted to near extinction. It was apparently Genghis Khan's favorite food, and so there's only a few thousand left in the world, and they're all basically in Kazakhstan and Uzbekistan. Last year there was a mysterious outbreak of the saiga, and giant herds were found just dead, scattered across the countryside in Kazakhstan. This year, we've been seeing a steady deterioration of all of the caribou populations. So all of the migrating, I guess you could say it's the migrating antelope type creatures of the northern climes are all endangered. Reindeer populations are plummeting, caribou populations, saiga populations, and most recently, there was a heat wave in Siberia. It reached the highest temperatures ever recorded this summer, and a mass die-off of reindeers from anthrax, and many humans in this remote part of Siberia also got anthrax. One child died of it, and this appears to have been long frozen anthrax bacilli in the permafrost. But most of the Arctic is what we call permafrost. It's ancient, alternately frozen water and soil, water soil. The very, very topmost of which melts in the summer and then refreezes each time with a little more and a little more and a little more. So the permafrost of Alaska, for example, goes down a couple hundred feet. And the deeper you go, just like anything in sedimentation, the more ancient it is. What we're seeing is a lot of melting in the permafrost. In some cases, it releases these giant, long frozen bubbles of methane that explode, resulting in creating these huge craters in the middle of the tundra and in Siberia. And in some cases, it's releasing long frozen microbes. The thing that worries me is that all our estimates with the IPCC and so on of what's the trajectory on climate change and what's going to happen to sea level and ice and blah, 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 with this incremental increase in temperature, this and this, all have underestimated the role of biology in hastening the pace of climate change. So we know that, for example, back to the permafrost, frozen in the tundra and in the permafrost all these millennia are microbes that are called methanogens. They make methane. Now, methane is 80 times worse as a greenhouse gas than CO2. If every 80 molecules of CO2 we've sent into the atmosphere were replaced with one molecule of methane, we would be in exactly the same boat we're in now, right? Except that methane is a more stable compound and will recirculate in the atmosphere for decades, whereas CO2 breaks down relatively quickly. Well, it turns out there is methane frozen in the tundra, and there are frozen in the tundra microorganisms that manufacture methane. So that could mean that we've underestimated the impact and pace of climate change by an order of magnitude. Similarly, we're finding microbes that play a huge role in the heat sink effect and in oxygen production in the oceans. Turns out they suffer tremendously with even tiny increments of temperature increase. So we're actually losing the oxygen production capacity of whole entire microbial populations. And about half of the oxygen you breathe is not made by terrestrial plants, it's made by ocean photosynthesizing microbes. So what keeps me up at night is kind of the reverse of thinking of epidemics, but rather, what if the good microbes are demolished? What are we doing inside of us as everybody in this room, has a far narrower range of diversity of species of microbes living inside of you compared to what your ancestors 8 or 9 generations back had in them. We've already lost an enormous amount of diversity because we don't live in nature anymore. You know, we're not exposed to the soil, we're not exposed to the diversity of plants that our ancestors were or that some indigenous peoples are, and we can compare what is inside them. Well, that change, that shift, that decrease in diversity that's happening inside of us is happening around the root systems of the plants. It's happening in the oceans, it's happening in the air, it's happening everywhere. And so I'm as worried as I've been for the last 30 years or more about emerging pathogens. I am now perhaps more worried about the disappearing microbes that play vital roles in the general ecology. Okay, that's the wrap. Thanks very much, folks.